Hello, and welcome to our webcast for May 3rd, 2019. My name is Christian Lebré, and this is Amy Asbrook, the director of Toujours Vivant, Not Dead Yet.
Hello.
Toujours Vivant, Not Dead Yet is a non-religious organization by and for people with disabilities and our allies. Our goal is to inform, unify, and give voice to the disability rights opposition to assisted suicide, euthanasia, and other end-of-life practices that discriminate against people with disabilities. Today's topics: the fourth interim report of medical assisted in dying in Canada. The second one is healthcare policies that lack foresight. Amy will help us through those subjects.
Yep, I'll do my best anyway. Okay, so the fourth interim report on medical assistance in dying on April 25th, 2019, Health Canada released its fourth and final interim report on the medical assistance in dying program. It covers the first 10 months of 2018. The last period before the new reporting system created by the federal monitoring regulations that went into effect on November 1st of 2018. So they've already had 3 interim reports. This is the last one. And we'll get into how these interim reports really are lacking some important information. The previous reports were released in June 2018, October 2017, and April 2017, covering 3 6-month periods from June 2016 through December 2017. Our webcasts of September 21st, 2018, October 20th, 2017, and May 5th, 2017, provide an overview of these documents. So, and there are links in the printed version of our webcast text. Yeah. Between January 1st and October 31st of 2018, so last year, 2,614 people died by assisted suicide or euthanasia, excluding Quebec and the territories. Quebec has only reported euthanasia figures up through March of last year, and Health Canada is not reporting data from Nunavut, Yukon, or the Northwest Territories because small numbers raise concerns for confidentiality. So since there's less than 7 cases in each of those areas, they're not reporting them.
So it's not relevant.
Right. Well, it's relevant, but it just, there are so few people that everybody knows them.
Yeah.
All but one of these deaths was by euthanasia. The others were by assisted suicide. The other one was by assisted suicide. So of the people who claim they want assisted suicide because it's their body, their choice, blah, 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 they all let somebody else do the euthanasia.
Only one do the right thing.
Only one of them actually takes the responsibility to do the deed.
The real thing.
Right. The average age of those who died was 72 years. Large urban centers of more than 100,000 people accounted for 56% of those who received assisted suicide and euthanasia, though they include more than 80% of Canada's population. So that's a little off.
Normally, when you have 80% of the population, you should have about 80% of the death.
Cases.
Space of 20% is kind of very, very, very awful when it's 100% testing ground.
Right.
Any statistical guy will tell you something wrong.
Something's off there. Okay, so that means that people from rural settings are overrepresented among those who choose medical assistance in dying. 44% of assisted suicide and euthanasia deaths come from only 20% of the total population.
Okay.
Yeah. So it raises important questions about the levels of palliative care and other services available in rural areas. Because as we know, assisted suicide and euthanasia are supposed to be the last extreme option for extreme cases where palliative care doesn't work. But it's really being used instead of palliative care where it's not available.
Yeah. So it's not in the thinking of the court for the Carter case.
Yeah, that wasn't what they had in mind.
Not really.
Okay. During the reporting period, most deaths took place either in hospitals or in the person's home. 1,148, or 44%, took place in hospital. 1,107, or 42%, were at the person's home. And if you remember from a couple of weeks ago, we had the summary report from Quebec, and that had only 20% of deaths took place in the person's home. So that's pretty different.
Yeah.
140, or 5%, of euthanasia were performed in a long-term care facility or nursing home. We've talked about how people who are living in long-term care facilities often don't want to be there, but because they don't have the services they need to live in the community, they're stuck. 103 were, or 4%, were done in a hospice, and 114, also 4%, were listed as other or unknown. And this is a catch-all category that includes unknown, undisclosed, and suppressed data. So suppressed coming from the regions where they're not enough to
almost anything that nobody could really put together.
Right.
So it's a bag of everything.
Right.
It.
And the document says it, quote, may include clinicians' offices, funeral homes, hotels or motels, and outdoor public spaces. So it's possible that people have been euthanized in all of those locations. We don't know. But they included them on the list, so presumably somebody's done it. 7% of the assisted suicide and euthanasia, or 193, were performed by nurse practitioners. The number of and proportion of euthanasia done by nurses is increasing. So more nurses are getting involved. People say there aren't enough doctors, so the nurses are getting involved. Health Canada estimates that assisted suicide and euthanasia, quote, accounted for approximately 1.12% of the estimated total deaths in Canada during this reporting period, unquote. And this is an increase from 1.07%, the estimate provided in the third interim report. While this might seem like a teeny increase, remember that we're comparing the euthanasia deaths against all of the deaths in the country.
Yeah, so it's looked like very tiny.
Right.
But you should compare orange with orange, not an orange with a Hulk.
Right.
Okay.
Right.
There's no compare.
Right.
But if you try to compare, it's very small.
Right. 1.17 to 1.12 in the period of 10 months is actually a fairly substantial increase when you compare it to all of the deaths in Canada. It's
a high rate of increase.
Right. Yeah, that's fairly substantial. Between December 10th, 2015, when Quebec's program began, and October 31st, 2018, at least 6,749 people died by assisted suicide and euthanasia.
Yeah, at least, because there is some not reported.
Right. First of all, there are ones that aren't reported, and there are ones that aren't included, the Quebec numbers and that kind of thing.
And don't forget the palliative sedation.
Yeah, continuous
palliative sedation.
It isn't counted anywhere except in Quebec. And continuous palliative sedation is not recorded in any of the other provinces at all. So,
but it is
it takes place.
Euthanasia too.
Right, but people do it. It just isn't recorded. There's no procedure or anything like that.
No, nothing. So you being killed and nobody take care of it.
Right. And if we look at the Quebec numbers, there are actually more continuous palliative sedations than there are euthanasia. Only 6 of those 6,749 people self-administered assisted suicide rather than euthanasia. Again, people are saying, I want control, but then they're giving away control to the doctors.
Only 6 do that, really.
Only 6 actually took control.
Oh.
The average number of assisted suicide and euthanasia deaths per month has increased by more than 300% since the first reporting period. So during the first 6-month period after the program got started, there were 85 per month. During the second period, it was 146 per month. In the third period, it was 181 per month. And in this last period, there were 261 each month.
81 to how much?
85 to 261.
It's 300%.
Yeah, more than 300%.
Ouch! That's orange over orange.
Yeah.
Okay, it's an orange and maybe a pineapple.
Right, and I think one of the reasons that Health Canada gave the other statistic that looks so small is because they don't want people to get panicked that the numbers are so big. But in fact, the increase is quite rapid. And we unfortunately won't have any more statistics coming out of the program for another year. And that will make it a year and a half before, another counting a year and a half. So we'll certainly be over 10,000 people who will have died by that time. And I think it's fair to say that.
And we talk about death.
Right.
Not just, I don't know, lollipop, okay?
Right, exactly. 10,000 people will have died in the program by that time. And I think people really need to understand this is serious. This is not just a few people. This is not exceptional cases and exceptional circumstances.
No, not at all.
Health Canada notes the MAID law is, quote, to be referred to one or more parliamentary committees for review at the start of the 5th year, which will be June 2020. So we had speculated as to whether they would start that process next year or in 2021, and at least Health Canada thinks it's going to be in the year 2020. So we don't know, but that's when we think.
Yeah.
Parliament, quote, may be expected to consider the Council of Canadian Academies reports in the context of such a review. So the review that Parliament's going to do next year, starting next year. Health Canada is betting heavily on the electronic reporting system. The first summary report is due to be released in the spring of next year.
And we know the success of the paying system.
Right, right, right. The federal payroll system hasn't worked very well, so we can't.
We wish it will work better.
Yeah, it would be nice if it worked better, but we already know from the Quebec summary report that in Quebec, where there is a verification system to sort of a verification check on the number of reports filed by doctors, that doctors are, a lot of doctors are not filing their reports. On the federal level, there's no such verification.
And there's no way to do it.
Right, right. They didn't make that part of their system.
In Quebec, it's kind of an accidental thing that it's possible to do it.
Right. No, they built it into the system.
Yeah,
There was this
they built it.
verification.
At least they verify.
Right, but I think, in fact, that Quebec will no longer have to do that verification because it's using the federal system.
Yeah.
So.
Oh gosh.
Yeah. So by the first summer report will be released in the spring of next year, and only one such report will be available when Parliament begins to examine the medical assistance in dying program. So it's going to use 4 interim reports that have incomplete information.
By their own.
Right, by their own admission.
Yeah.
It's very possible that problems with the monitoring and reporting system will only be detected during the preparation of the report or following the release of the first statistical summary. Any necessary corrections to the system would therefore be made 18 months after the system goes online, or the spring of 2020, right? And the corrected data won't appear for at least another year, or the spring of 2021 at the earliest. So they're not really necessarily going to have good data to be making decisions about whether the program is working.
That's the least that we could tell.
Yeah. We've already described some of the ways in which the monitoring system falls short of providing the information necessary to determine if all eligibility criteria are being met and all safeguards are complied with. Some of these include, and we gave a link to the webcast where we talked about the monitoring system. There's no way to know if the person is subject to external pressure, either from direct coercion or from life circumstances. Yeah. There is no way to verify that doctors are actually filing reports on euthanasias they perform. And I can definitely envision a scenario where a doctor starts to fill in the electronic form and they run into questions and they can't really answer them, and they sort of give up on the form, and the euthanasia doesn't get reported. You know, they don't complete the form. And the form isn't recorded if it's not completed, and nothing is reported.
They will soon know that if they do not report, nothing happened.
Right. Because there is no plan to detect and correct errors in the reports or fill in incomplete information.
So less paperwork, less everything.
Right.
Everybody's happy, but you're dead.
And more, and nobody knows it. The demographic information is insufficient to detect discrimination based on race, disability, indigenous status, language, gender, or economic status. There's no, they aren't collecting that information.
Impossible, not enough information.
Right. There is no information on the reason for the request, why a person has asking. Basically, they assume that a person having suffering is the reason.
Yeah, it's just an assumption. But you know what you
yeah.
tell about the word assume.
Yeah, you make an ass of you and me. And so there's no information about the reasons for a request or the nature of the person's suffering. Is it psychological suffering? Is it physical suffering? Is it pain? Is it choking? Is it breathing difficulties? What is the physical, what is the suffering?
It should be very, very important to get those information. Why? Just to be fair about the law.
Right. Just to have basic information. This is basic. And finally, the documentation gives no indication of whether suicide prevention intervention was provided or the person has the necessary supports to live without pain in his or her own home.
It should be the first thing to do for administer this kind of law.
You would think.
That's what I think.
I would think. And we're not experts. But,
no, we are not experts. Don't
listen to us.
Yeah, don't do nothing about it.
At this point, it appears Parliament will review the medical assistance in dying law on the basis of 4 interim reports, which Health Canada admits contain incomplete information, and 1 statistical summary from the electronic reporting system, which will probably have some bugs and can't guarantee that doctors report every euthanasia performed. This is why it is so important for advocates to work together over the next year to document the problems of the medical assistance in dying program, because this is the only way that we can demonstrate in a way that will be acceptable to Parliament, that they will believe all the things that we've talked about that don't work in the program. So we have to work together, and we need your help. Okay. Our next topic is healthcare policies that lack foresight. A couple of articles reminded us recently of the negative human and economic consequences of healthcare policies that try to save money in the short term. The first was the untimely and unnecessary death of Carrie Ann Lucas in February of this year. An article by Sarah Kim in Forbes magazine recounted.
Forbes is a very serious
magazine.
Yeah.
It recounted what happened when Carrie's health insurance provider, United Healthcare, refused to pay for the inhaled antibiotic she was prescribed to treat a lung infection she contracted in January of 2018.
They use a substitution.
Right. He said, no, we won't give you the one you really need. We'll give you something else. The inadequate substitute caused a harmful reaction and failed to clear up the infection, leading to the loss of her voice, multiple relapses and hospitalizations, costing Carrie her life and the insurer hundreds of thousands of dollars, all for a short-term savings of $2,000.
Yes. For saving $2,000, you spend $100,000.
Right. And
that's a saving. Yeah.
And the human cost, obviously, I mean, it was one thing. Carrie was a lawyer, and it was really hard to watch her having to deal with losing her voice as a lawyer.
Yeah.
And the way people treat you when you can't speak.
And even a lawyer could not win against insurance company.
Right.
It's
right.
Unbelievable.
And then the human cost became the ultimate human cost, which is that she lost her life. The second reminder came from 2 blog posts by Bill Peace, who is a member of the board of Not Dead Yet, on April 10th and April 24th, which described his difficulty in obtaining wound care and the lack of empathy and respect offered by medical professionals providing that care. So he has pressure sores that have gotten out of control. And so he's trying to get care for them, but is not having a lot of success. Mr. Peace describes dealing with pressure sores in stark terms. Despite following wound care recommendations to the letter, quote, I am in worse shape today than I was 6 months ago. No matter what I do, I cannot relieve pressure on all 4 wounds. This is a lethal problem. The solution is obvious but unaffordable. A clinitron bed or air fluidized therapy would relieve all pressure. So there are beds that you can be on that it's like being on a cloud. Your body doesn't, it's like being held up by air.
Yep. So
that the weight of your body does not create pressure on the skin to make the sore worse, and that's how you heal. To purchase or rent such a bed would cost well into 6 figures, so that's $100,000. And no insurance company will cover such treatment. For me to access a clinitron bed, I would need to become septic, which is to have an infection that spreads through the bloodstream. If septic, I would be hospitalized and placed in a clinitron bed. Once the sepsis is cleared up, I would be sent home and to the same bed that caused my wounds in the first place.
Yeah, you get back to the thing
Right.
who caused your trouble, and you get your trouble again and
Right.
again and again.
Right.
Ouch.
An obvious pattern would emerge: bouts of sepsis and increasing number of wounds and hospitalizations. Over time, my body will weaken. Sepsis will become increasingly difficult to treat and recover from. I will likely catch a very bad infection in the hospital and succumb to the infection. This is a miserable way to die, and it is a human rights disaster.
Yeah, I agree.
It would make sense for managed care organizations, which claim to focus on prevention and wellness, to invest in preventive treatment to avoid greater expense and suffering in the long term. So in this case, that would be for them to, pay to rent Bill a clinitron bed for his use at home, period. So he won't have pressure sores. That would be smart.
And save his life.
Right.
And save money to the hospital.
Right, exactly. But human nature and human institutions don't seem able to handle long-term.
It's remember the government of Quebec. So few years ago.
Actually, it's Ontario, but.
But it remembered the government of
Quebec
a few years ago.
Right.
Couillard government.
Actually, it's not Ontario. It's Colorado. But anyway.
Doesn't matter.
Yeah.
Government look alike in many ways. Anywhere.
Human institutions don't seem able to handle long-term planning, which is why we are facing infrastructure breakdowns, exhaustion of natural resources, and climate change. So
yeah, just look at Saint Matt on the lake.
Yeah.
They build a dam over a lake and build a house in the lake.
Right.
And what happened?
When the
dam was
breaks,
not tight enough, and
it breaks.
Was built too cheap, and it break, and was flooded.
Right.
Hey,
Yep.
never build in any place who could be flooded.
Right, and this is how humans need to evolve to be able to think in the long term, and we haven't managed that yet. And it has greater and greater consequences.
Oh, yeah.
But Bill points out that the wound treatment issues go beyond poor planning and lack of foresight. They are the result of disability discrimination.
It's worse.
Right. People who need wound care are disabled and disadvantaged. Quote, "We wound care patients are downtrodden. Obese people, amputees, diabetics, the paralyzed, and the occasional terminally ill patient, we are a scruffy lot." So, we're not, people who have wounds are not the most desirable, celebrities in society. And the way they're treated is an indicator of that. Doctors say 90% of wound care patients don't comply with treatment, but they do not explain how a person is supposed to keep pressure off a wound when they have to sit for hours in the doctor's waiting room or change dressings every day when they can't afford the dressings.
So that doesn't even have the transport to go to in Quebec to CLSC.
Right, but
how you could get your?
I mean, you can. Delivery by the pharmacy is one thing, but if you cannot afford to pay for the dressings, then you can't change them. And if the doctor says you can't sit up for more than 10 minutes at a time, how can you make a meal and eat it? You can't. So either you're starving or you're not complying. And then the doctor said, "You're not compliant. You're not compliant." He describes being seen as a wound and not a human being. He compares the complete coverage by his insurer of cardiac care and the well-appointed cardiac care suite with the $20,000 deductible, the grimy carpet, worn furnishings, and broken equipment of the wound care area. So very different. Just, care for your heart. Hey, everything's covered. It's a nice waiting room. Care for your wounds. Oh, not so much. Yeah. Mr. Peace notes the difference between empathy and sentimentality and pity in the delivery of healthcare. Quote, empathy, in my estimation, is the ability to acknowledge and identify the similarity of the human condition and to create a foundation of mutual respect. He said, and that's the end of that quote. He says that the other emotions come from, quote, a position of superiority and fear, unquote, and absolve the giver from making systemic changes that would benefit all people. So that's, he's not saying he needs pity. He's not saying he needs sentimentality. He says he needs respect and empathy.
Yes, he needs.
Empathy being mutual respect. In addition to coverage of equipment to prevent wounds, pressure relieving beds, and other things, as well as dressings and medical supplies, Bill Peace says apathy must be rooted out with vigor. Wound care must be understood in the larger social context of social supports that people need but don't have. So again, how do you make a meal and eat it if you can't sit up for more than 10 minutes? Wound care patients are not compliant for a reason. Instead of blaming the victim, barriers to compliance must be addressed by wound care professionals. So instead of saying, well, you're not compliant, then, they need to figure out ways for people to be compliant, like providing them with beds that don't cause pressure sores.
Just look forward.
Right.
What's next?
Right. Wound care nurses must lead the way, says Bill Peace. Only they can end the apathy that grips the field and provide the empathy that patients need when they are isolated. And, a lot of people with pressure sores are elders who are not being moved adequately in their beds, which is how the sores develop. A lot of people with diabetes who aren't being checked carefully enough with their feet. I check this guy's feet every twice a week when we take a shower together. So, isolation is a problem, and that's a social ill that we need to resolve. Okay, so if you want more information about the topics that we discuss here, you can visit our Facebook page at facebook.com/toujours vivant, not dead yet, all one word. Visit our website at tvndy.ca. You can send us an email at info@tv-ndy.ca, or you can follow us on Twitter @TVNDY. Thanks to Christian for helping out. Thanks to you all for being there. We'll see you next time.
See you soon, guys.
Bye.
Take care. Bye.